This is the Psychcast by MDedge, where we bring you interviews with leaders in the field of psychiatry and psychology and masterclass lectures. I'm the voice of MDedge podcast, Nick Andrews. And welcome to episode 149 of the Psychcast by MDedge. I am Nick Andrews. A quick reminder, you can email the show at podcasts@mdedge.com if you have any feedback on any of our weekly episodes or on our bi-monthly clinical correlation drop with Dr. Renee Kohansky. Again, that's podcasts@mdedge.com. Okay, coming up in episode 149, we have a masterclass lecture on marijuana's effects on psychiatric disorders. A few episodes back, say about 10 or 15 episodes back in your feed, we did a masterclass lecture on current literature in marijuana, and that episode was so successful it seemed like something that all of you wanted. So here we are with another masterclass lecture, but this time it's about how marijuana impacts psychiatric disorders. The show notes this week were written by Dr. Jacqueline Pusada. Okay, without any further ado, please welcome our masterclass lecturer, Dr. Martinez.
I'm Diana Martinez. I'm a psychiatrist at the Columbia University Medical Center in the Department of Psychiatry. And today we'll be talking about the interaction between cannabis and psychiatric disorders. I have no disclosures relevant to today's talk, and all of my research is publicly funded. I do want to point out that in today's conversation, I'll be talking about cannabis. And when I say cannabis, this is really the same as marijuana. I use the term cannabis because this is a scientific term for the plant. So I'm actually going to start with a brief history of cannabis. Cannabis has been used for centuries in India as both an intoxicant and a medication. And medicinal texts in China, dating back to about 100 BCE, describe cannabis as being helpful for mood, appetite, gout, and rheumatism. In the 1930s, William O'Shaughnessy, an Irish physician, joined the British East India Company. And there he studied cannabis and submitted reports to medical journals on its ability to improve pain and rheumatism, to treat spasticity and tetanus, and to treat seizures. It became quite well known and widely used in England, and Sir Russell Reynolds, who served as a physician to Queen Victoria, argued that cannabis should be used for pain instead of opioids because morphine addiction was rampant at the time in Victorian England. In the United States, cannabis was used medically and recreationally until it was restricted in 1937 and outlawed in the 1950s. In 1970, President Nixon signed the Controlled Substance Act, and cannabis was placed into Schedule I. And as you may recall, Schedule I is a class of medications that have a high potential for abuse with no accepted medical use. In other words, cannabis cannot be prescribed by physicians for any reason. Even at the time in 1970, placing cannabis into Schedule I was debated, and it was thought of as being too harsh of a measure for a medication. Oh, God. So even at the time when cannabis was placed into Schedule I, it was debated as being too harsh of a measure. And since 1970, there have been multiple petitions submitted to the DEA to move cannabis off of Schedule I so that it can be prescribed by physicians and studied more readily. However, this has not happened. Yet, despite the law, the federal law, cannabis has been approved in many states for medical and recreational use. And at present, cannabis is approved for medical purposes in 36 states and for recreational use in 15 of those states. So now I'm going to talk about cannabis as both an intoxicant and a medication. And as physicians and psychiatrists, we are familiar that many medications are both a therapy and a substance of abuse, such as opioids, amphetamines, benzodiazepines, ketamines, and I'll add cannabis to this list. As a result, these drugs, including cannabis, can have a therapeutic or a detrimental effect. So cannabis has the potential to cause a substance use disorder or an addiction, and it can also worsen psychiatric disorders, such as mood, anxiety, and psychosis. And we'll talk about this today. However, cannabis also has the potential to treat some psychiatric symptoms, and we'll discuss that as well. Now, the cannabis plant contains about 100 cannabinoids, and the main ones that have been studied are THC, which is short for delta-9 tetrahydrocannabinol. This is the agent, the molecule in the cannabis plant that creates high, and CBD, which is short for cannabidiol. CBD does not create a high, it has few subjective effects, and there's a lot of interest in CBD for treating different disorders, including psychiatric disorders. So when it comes to cannabis and psychiatric disorders, there are really two main questions. And the first one is, does cannabis use worsen psychiatric symptoms in patients who use it? And the second question is, does cannabis cause mental illness in people who use it? And we'll start with the first question. So most of what I'll be talking about today with respect to cannabis use in patients with psychiatric disorders comes from a report published by the National Academy of Sciences, Engineering, and Medicine in 2017. It's called The Health Effects of Cannabis and Cannabinoids, and it really is a remarkable resource if you have any interest in reading further on this. So these are studies in patients who use cannabis themselves. So this is THC containing cannabis, and looking at the outcomes or the effects that this might have on their psychiatric symptoms. And we'll start with depression. So overall, there is a lack of data investigating an association between cannabis use and depressions, meaning that we simply don't know if cannabis use in depressed patients either worsens or improves the disorder. It's simply a big question mark. With respect to bipolar disorder, there's moderate evidence of increased symptoms of mania and hypomania in patients with bipolar disorder who use cannabis regularly. In anxiety disorders, there's limited evidence of an association between near daily cannabis use and the increased symptoms of anxiety. And in PTSD, there's limited evidence of an association between cannabis use and increased symptoms of PTSD in patients diagnosed with this disorder. Now, you'll note that this report uses terms like limited evidence and moderate evidence. And I'll point out that limited evidence means that there is an association has been seen, but it is not strong and remains inconclusive. Moderate evidence says that there's stronger evidence, there's more supportive data, still not conclusive, but there's more of a concern. So again, moderate evidence is in bipolar disorder with mania and hypomania, and there's only limited evidence showing that cannabis worsens anxiety disorders or PTSD. There is some evidence showing an association between cannabis use and an increase in positive symptoms of schizophrenia among individuals with a psychotic disorder. There's no clear evidence of an association between cannabis use and worsening of negative symptoms of schizophrenia. And there's actually moderate evidence of an association between cannabis use and better cognitive performance in individuals with psychotic disorders. Now, in summary, what does this mean? What can we say about the impact of cannabis use on the course of illness in psychiatric patients? Overall, we can say that the data is strongest, showing that patients with bipolar disorder could have a worsening of their hypomania or mania, and that patients with schizophrenia may have a worsening of their positive symptoms of psychosis. There is some limited evidence that heavy cannabis use might worsen anxiety disorders. But overall, this really highlights the importance of clinical judgment. In some patients, cannabis use might have no impact on their illness, but other patients, it might have an effect. But in patients who are refractory to treatment or stop responding to treatment, it's important for the clinician to consider cannabis use as a potential factor. However, it's also important to understand why a patient might be using cannabis, especially regular use. And common reasons that patients give for using cannabis include chronic pain, anxiety, and insomnia. So a clinical patient who's using cannabis and not responding or no longer responding to a previously effective treatment, and you think that cannabis might be a factor, it's important to look and see if they're using cannabis to address symptoms like anxiety and sleep, and maybe these symptoms could be addressed with other therapies instead. Okay, so now we're going to switch gears and we're going to talk about cannabis use and the development of a mental illness. So again, I'm going to be referring to the report published by the National Academy of Sciences looking at this question. So there is moderate evidence of a small but increased risk of developing depression in heavy cannabis users. There's also limited evidence of an association between cannabis use in regular or daily users and the development of bipolar disorder. And there's moderate evidence of an association between cannabis use and the incidence of social anxiety disorder. Now again, it's worth noting that these studies show an association between cannabis use and the development of a psychiatric disorder. However, we can't assume that cannabis use causes psychiatric disorders because we simply don't have data that shows this. Now, there's been a lot of attention paid to the potential link between psychotic disorders and cannabis use, especially daily or high potency THC. And there have been studies that suggest that there's an association between cannabis use and an increased risk of psychosis and the symptoms of schizophrenia. And overall, the data indicate that patients at clinical high risk for a psychotic disorder who use cannabis are at risk for the earlier onset of a psychotic-like symptoms, poorer prognosis, and a greater likelihood of being diagnosed with schizophrenia. Thus, cannabis use in clinically high-risk patients likely worsens the prognosis. However, as previously with depression and anxiety and bipolar disorder, we can't assume that cannabis causes schizophrenia or causes a psychotic disorder. Now, with respect to cannabis use causing a psychiatric disorder, we can assume that the greatest risk of cannabis use is the development of a substance use disorder. So people who use cannabis are at risk of developing a substance use disorder and meeting all the DSM-5 criteria, which includes not meeting their obligations, engaging in risky behaviors, the development of tolerance, and failed attempts to quit. It's worth noting that frequent cannabis use is associated with withdrawal symptoms, which includes irritability, sleep problems, decreased appetite, cravings, and restlessness. And research studies have estimated the risk of developing a substance use disorder among cannabis users. And overall, these studies suggest that 9% of people who use cannabis will become dependent on it or would develop a substance use disorder. However, this percent increases to 17% in those who are using in their teenage years. So among teenagers, cannabis use is clearly more risky with respect to developing a substance use disorder than adults. However, it's also worth noting that among teenagers with depression or ADHD, these are children who are very high risk of misusing drugs, especially cannabis and other drugs like alcohol. So in a teenager who's using cannabis, especially on a regular basis, it's worth looking at underlying psychiatric symptomatology, like depression or ADHD, to see if this is driving their risky cannabis use. Okay, so now we're going to switch gears again, and we're going to discuss the use of cannabinoids as potential treatments for psychiatric disorders. So previously we talked about the risks of cannabis. Now we're going to see if cannabinoids used in a medical setting can serve as treatments for psychiatric disorders. I'll start this discussion by saying that there's a tremendous shortage of reliable data, largely due to regulatory barriers, meaning since cannabis is a Schedule I drug, there's a lack of studies that use a prospective double-blind analysis, which is desperately needed and badly needed to support the use of cannabis as a medicinal product. Now, to date, placebo-controlled studies have been done to an extent with both cannabis plant, cannabis extract, which usually contains CBD and THC mixed together, and the FDA-approved drugs dronabinol and nabilone. Dronabinol is delta-9 THC made in a pharmaceutical factory, and nabilone is a related molecule. So dronabinol and nabilone are very similar. Now, the strongest support for the medical use of THC includes pain, especially chronic pain. And this has been shown in studies using dronabinol and nabilone, the cannabis plant, and cannabis extract. It's been estimated that 5 to 20 milligrams of oral THC is about as effective as 50 to 120 milligrams of codeine. However, head-to-head studies comparing cannabis and opioids in the treatment of pain are few and far between. The pain conditions that have been studied include neuropathy caused by diabetes or HIV, cancer pain, fibromyalgia, and multiple sclerosis. Cannabinoids have also been shown to be helpful in spasticity. And with respect to the FDA-approved drugs, dronabinol and nabilone, these are FDA-approved for chemotherapy-induced nausea and vomiting and appetite stimulation in AIDS. Now let's look at the limited evidence, the more moderate evidence for THC. There is moderate evidence showing that THC improves short-term sleep outcomes in patients with obstructive sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. There's some limited but promising evidence showing that dronabinol in Tourette syndrome can reduce the tics and obsessive symptoms. However, this has been shown in small studies, one placebo-controlled and one crossover, and needs to be replicated in larger studies. There's also a small study showing that nabilone may be helpful in treating PTSD. This was done in patients who had ongoing PTSD symptoms despite treatment, meaning that they were a refractory group of patients who weren't responding well to existing treatments, and nabilone was added as an additional pharmacological agent. And the results show that their nightmares improved and some of their PTSD symptoms. But again, this is a small study and is in need of replication. With respect to cannabis and OCD, there have been 2 small studies performed. In one study, the smoked plant was compared to placebo, and both decreased symptoms in OCD. So there was no difference between smoked cannabis and placebo. However, in a follow-up study, nabilone, 1 milligram taken twice a day, combined with exposure therapy, improved OCD symptoms. So this is an interesting approach. It's combining nabilone, which is synthetic THC, and combining it with exposure therapy and seeing a response. However, this is again a small study that needs to be replicated in a larger group of subjects. So now we'll switch and we'll talk about the medical evidence for CBD. That was THC, now we're talking about CBD. And of course, the strongest data for CBD is in epilepsy caused by Dravet syndrome and Lennox-Gastaut syndrome. And that's been shown in a large multi-site clinical trial. However, when we're talking about CBD for psychiatric disorders, the data is more limited, but some studies have been done. So we'll start with schizophrenia. And research on the ability of schizophrenia to improve psychotic symptoms in schizophrenia is mixed. There have been 3 studies performed using different methods. And 2 of these studies showed promising results, while 1 did not. 1 was a negative study. The studies that showed a positive effect used high doses of CBD, 800 to 1,000 milligrams a day, which is actually similar to the dose that was used in childhood epilepsy studies. The negative study used 600 milligrams a day, which is a lower dose, but still on the high side. So of the 2 studies showing a positive outcome, 1 used CBD as an add-on therapy to the schizophrenic patient's existing regimens, meaning this means that the patients were symptomatic despite treatment, and CBD was added to see if treatment could improve. And the results showed that CBD did decrease the positive symptoms of schizophrenia, although the effect size was modest. The other positive study looking at CBD and schizophrenia compared it to amisulpride, and both groups improved. Both the CBD group and the amisulpride group improved in schizophrenic patients. However, there was no control group, and so that is an open question with respect to CBD compared to amisulpride. So overall, I'd say that the data in schizophrenia is promising, but it's mixed and in need of replication. There have been some very small studies looking at CBD for social anxiety disorder and substance use disorders. The studies in social anxiety disorder used 1 single dose of CBD, 400 and 600 milligrams, and it showed an improvement in patients with social anxiety. However, this is again a small limited study with 1 dose, and larger studies need to be done with repeated dosing. With respect to substance use disorder, there have been 2 studies looking at CBD, 1 for opioid use disorder and the other for cannabis use disorder. The study in opioid use disorder showed that CBD reduced cue-induced craving for heroin, which was done in the lab with videos. So videos were used to incite craving for heroin, and it showed that CBD was more effective at inhibiting that than placebo. So this is an intriguing result, but it needs to be followed up with repeat dosing studies. Another study has been done looking at CBD for cannabis use disorder. And this study investigated 400 and 800 milligram doses of CBD and showed that CBD increased abstinence over placebo, but the effect was small. So in this study, subjects decreased their cannabis use by 0.5 and 0.3 days per week. So that's half a day a week improvement in reducing their cannabis use, which was statistically significant. But at this point, we don't know if this has a clinical impact on the actual diagnosis of a cannabis use disorder. And this study will need to be replicated. So in summary, I'll say that these are my thoughts on the promises of medical cannabis. The most promising immediate use in my mind is the use of THC for pain. THC has the potential to treat pain and could be added to the armamentarium of pain medications that we use today. The risk of using THC for pain is that of intoxication and the development of an addiction. This is higher than the risk seen in other pain medications like NSAIDs, but lower than the risk of opioids. THC may have promise as an anti-anxiety medication, perhaps in PTSD and OCD and maybe other anxiety disorders. However, larger, carefully controlled studies are needed, and especially looking at THC plus behavioral treatments. This is probably the most promising use for THC, is to combine it with behavioral treatments. With respect to CBD, there is a promising signal that it may be helpful in schizophrenia, anxiety disorders, and perhaps substance use disorders. But again, we need replication and we need larger studies. And I'll just come back to history. One of the greatest reasons why we don't have these studies is because both THC and CBD are Schedule I drugs. And while this is in the process of changing, it has certainly impeded research at this point. Nonetheless, there's a significant interest in studying cannabinoids as potential treatments for medical and especially psychiatric disorders. And that concludes my discussion of cannabinoids with psychiatric disorders. I'm available if anyone needs to contact me. You can look me up by searching Columbia and Diana Martinez. You'll find my phone number and my email address. And if you have any questions or wish to contact me, please reach out to me. And thank you for listening today.
And that's a wrap on episode 149 of the Psychcast by MDedge. The Psychcast is produced by MDedge editors Gina Henderson and Jeff Bauer. All of our podcasts are produced by executive editor Kathy Scarbeck. Our Masterclass guest lecturer this week was Dr. Diana Martinez. The show notes are authored by Dr. Jacqueline Posada. I'm the voice of MDedge Podcast, your audio editor and your audio producer, Nick Andrews. You're listening to the Psychcast.